really, I do appreciate all of you being here. Yeah, like I say, hopefully we can learn something. I won't be taking too much of your time, maybe about 20 to 25 minutes at the most. And listen, if you guys have any questions, please just either put it on the chat, or if you want to, you're more than welcome to just unmute and talk. Even if you want to put on your video and talk, that's no problem. I'll bring it up on the screen, and however you feel it's best. The reason why I say that is because I know I'm talking about these things from a point of experience, but I'm trying to teach it to you guys who are maybe learning it for the first time, or who maybe are still getting the hang of ECGs and things like that. So yeah, without further ado, let's start. So let's get into the ECG itself. And so what we have here is a 60-year-old man who presents to your emergency department with chest pressure and diaphoresis. Now, the one thing I can tell you, even before we get into the actual ECG itself, diaphoresis is very difficult, is very different to sweating. If you've never seen somebody who's diaphoretic, it's actually quite an amazing sight, because what you have is a person who looks as though they have been doused in water. Literally, I mean, it's sweat, but they look as though they've been doused in water. So if you've never seen it, don't stress. When you do see it, you will recognize it, right? And diaphoresis is quite particular to a few conditions. And the most common is myocardial infarction. Now, there are a few others as well. One of the other common ones you'll find is tick bite fever, especially if you work in a rural area. Sometimes with aneurysms as well, you do sometimes find patients becoming diaphoretic. But I must be honest, 90% of the time when you see a patient who's diaphoretic, it means a myocardial infarct. Now, where most of us have a problem is that, number one, how do I recognize a myocardial infarct? And number two, how do I get somebody who can do something about it to come and assist me with it? And the thing is that you need to speak the language of the person who's going to come. So in this case, I need to speak the language of the physician to be able to tell him, okay, listen, there's something going on. Now, we can't cover all of ECGs in one. So let's have a look at this particular ECG and let's see what's going on. So here we have a typical ECG. Sorry, I just want to bring up the spotlight so it's a bit easier for you guys to see. So we have leads 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. And then these are just rhythm strips. Now, these are to assist you in deciding on the rhythm. Okay. Now, when you look at an ECG, the first thing that you need to have a look at is the axis. So the axis is which way is the electricity flowing. And the way that it should be flowing is from the, all right, let's just draw it over here. So it should be running from the top right of the heart to the bottom left. This is the way that it should be running, okay? And the way that you know that it's running that way, just quickly, is to look at leads 1 and AVF, okay? And the reason for that is lead 1 sits here, okay? And lead AVF, sorry about that, and lead AVF sits here. Now we're going to talk about this a bit more, right? So don't get worried if you're a bit confused. So we're looking at electricity that's moving towards the two of them, okay? So let's have a look at our lead 1 over here. So our lead 1, we're looking at our QRS complex, and it's positive, it's pointing upwards, okay? And if we look at our lead AVF, it's kind of biphasic, but more positive. So we can say that we have a normal axis. Okay, now if this seems a bit, you're a bit lost, or you're, okay, maybe Dr. Mohammad's going a bit too fast, I don't really understand what he's talking about, I've got a whole set of lectures. There's 4 of them that cover this very extensively. So just on the axis, there's like a half-an-hour lecture, and then we're going to talk about rhythm and things like that. So there's lectures about all of these things. So if you are a bit lost, just go back there and just have a look. I know all of us, listen, I was the same when I was in university. My main thought of the day was, do I really get this duvet off me and go to class, or do I just stay inside? And unfortunately, most days I chose the duvet, and I missed out on quite a bit myself. So I know how it feels. I'm sure most of you weren't like that. But if you were anything like me, I know sometimes, you just get lost immediately because you may not understand the concept. So if you are lost, don't stress. Just go back on the YouTube channel and have a look at this. All right. So that's the first thing that we look at, right, which is the axis. Okay, so we have a normal axis. That's good. Now, let's have a look at the rhythm. So the first thing that we're going to have a look at for the rhythm, let's have a look at lead 2. So we look at the P wave, which is this one here. So the P wave is just telling us about the atrium and how it's contracting. Okay, so in this case, we have nice P waves. They're contracting nicely. There's not much going on. So the atrium is contracting quite well. Then the second thing we look at is we look at the PR interval. So that's the different distance between the middle of the P wave and the R wave. Okay, so it should be between 2 to 4 blocks. So in this case, it's 1, 2, about 3.5. So it's within normal. Below 2 is a problem, and above 4 is a problem, but that's not an issue for today. Then we look at our QRS complexes, and we see does a QRS follow every P? Now, the QRS complex is your ventricular contraction, and your P wave is your atrial contraction. So you're checking, is your ventricle contracting after your atrium? What you would have learned in primary school as lub dub. All right, so we all learned our heart sound was lub dub, which is 100% correct. So the P wave represents lub, and the QRS complex represents dub. So we're checking, do we have a lub? Do we have a dub? Does the lub and the dub occur at a good pace from one another? Are they separated correctly? And does a QRS always come after P? In other words, does the ventricle always contract after the atrium? And we see in this case that it does. Okay. Then the next thing that we look at is our QRS complexes themselves. Are they narrow or wide? So narrow complexes generally mean that the ventricle is receiving its impulse from the atrium. So in other words, the SA node is passing the message on to the AV node, right? So starting from the vagus nerve and then going on, okay? So in this case, you can see it's happening. And if you have a wide QRS complex, that normally means that the ventricle is functioning on its own. So that's another discussion, and we can get into that at some other time. But for now, we'll just say that, okay, that seems to be okay. And then we check for regularity. So in other words, is lub dub occurring at a regular interval? So is the heartbeat regular? And in this case, it is. So we've got a regular rhythm, or what we would call a sinus rhythm. Okay. So a regular rhythm that fits all of those criteria: a normal P wave, normal PR interval, a QRS after every P, narrow QRS complexes, and the PQRS groups are occurring regularly is a sinus rhythm. Now let's have a look at the rate that this patient's heart is going at. Now, even though we're going through this in a slow manner, I mean, generally when you're in front of the patient, you would try and do these things as quickly as possible, but it's good to do it in order. The reason being, if you miss something, it's very difficult then to change your diagnosis. We are humans, we don't want to admit that we are wrong. So unfortunately, it's good to do it in step, in sequence, so that you actually make sure that you do it properly. Now, I'm going to work out the heart rate here, but nowadays, all of our ECG machines have a nice readout at the top that tells us exactly what our heart rate is. So yeah, we don't have to do this, but in this case, it's 1, 2, 3, 4, 5, 6, 7. So 300 divided by 7. So that's just about 40 some odd beats per minute. Okay, so that's what we're looking at over there. So this patient has a bradycardia and a sinus rhythm. So they have what we call a sinus bradycardia. Okay, so that takes us through the first and the simplest parts of looking at the ECG. Now comes the part that most people get a little bit lost on. So what we do is that we group the ECG leads into different categories. Now, what we're going to do is let's have a look at those. Sorry, let me just get this out of the way. So we're going to come back to the ECG, but I just wanted you guys to have a look at this first, because this is a thing that sort of trips up everybody quite a bit. And now, please don't worry about the chest leads for right now. Luckily, the ECG that we have concentrates mainly on the limb leads, which is the one that we're going to look at now. So if we look at leads 2, 3, and AVF, and remember, leads 1, 2, and 3 are not physical leads. They don't exist on the body. These are augmented leads. These are leads that are created by the ECG machine. So if you look at these, 2, 3, and AVF, and if this is your heart, they're all looking at the inferior part of the heart. So they're looking at the bottom part of the heart. They're watching electricity or the electrical impulses that are passing through the inferior part. So these are called your inferior leads. AVR, which sits on its own there on the right-hand side, which on the body you could put on the wrist, on the elbow, on the shoulder. It doesn't make a difference. It still looks at the right side of the heart. Now, AVR is often called the forgotten lead. There's a few uses for it, but we won't get into that in this particular session. And if you look at leads 1 and AVL, which are here, these actually look at the left lateral side of the heart. So if your heart is here, it's looking at the left lateral side. So these are called the high lateral leads. They're looking at the high lateral leads. Okay. We can talk about the chest leads. So you've got V1 and V2 that are looking at the septum. You've got V3 and V4, which are looking at the anterior part of the heart, and V5 and V6, which are also looking at the lateral side. The only difference is that they are looking at it sort of in a horizontal plane, and 1 and AVL are looking at them in a vertical plane. So what you're having, if you had to actually look at the heart, let me try and draw it out here. So you've got a horizontal and you've got a vertical. So you would have, for example, lead 1 is here. Lead V5 is, oh, sorry, I'm not very good at that. Okay, let's just put V5 is there. Let me just put a 6 over there. And then let me just put AVL, or let me just put an L. So that's basically how they're looking at this left lateral side of the heart. If you can imagine just that section of the heart that's sitting over there, that's how these 4 leads are looking at them. So they are, sort of grouped together in their own little space to have a look at the lateral side of the heart. But anyway, not to worry about that. Let's just concentrate on these for now. So what I'd like to do is let's go back to our ECG and let's look at our inferior leads. Now we've got leads 2, 3, and AVF. Can anybody tell me what they notice on these leads, particularly lead 3 and lead AVF? And if you don't, it's no problem. Don't worry, there's no pressure on anybody to answer, but if somebody wants to, that would be great. You can either talk or you can put it up on the chat. I'll give it a few seconds. So specifically lead 3 and lead AVF. Is there anything that anybody notices? I see everybody's a bit shy today. That's no problem. I talk very fast and I know I'm very intimidating. So, I don't blame everybody for being a bit quiet. But in any case, what we are seeing over here, sorry, let me just draw it out here. So if we look at leads 3, and if we look at lead AVF, what we see are ST depressions. Okay. So, and if we look at lead 2, you'll notice there's no ST depression over there. We can even draw it out here. So here you can see there's no ST depression. Okay. So we are seeing ST depressions over here. That's not the end of looking at our ECG, but it's just where we are for now. So let's look at our other limb leads. So here we have leads 1 and AVL, which we look at now. So if you look at lead 1, let's draw that line across. Sorry, not a very good line. This is why I became a doctor and not an artist. But anyway, so what do you notice there? If you look at that, you'll see that you have ST elevations. Okay. So you have ST elevations. We can just quickly look at the last one, which is AVR. And on AVR, we can see there's a very slight ST depression, but it's mainly noted in leads 3, and leads AVF. Okay, so what have we figured out so far? We've figured out that we've got a sinus bradycardia. We've got ST elevations in leads 1 and AVR, which are our lateral leads. And we've got ST depressions in leads 3 and AVF. Now, what I want to do is just bring you back to this drawing that we were looking at on the other side with the leads. Now, here's leads 1 and AVL. They are on the high lateral side. And what we have when we were looking at this particular ECG is that we could see, and I'm going to try and draw it out here, sorry. We saw an ST elevation, all right. So that means if there is an infarct on the lateral side of the heart, 1 and AVL are picking it up, okay? I hope you guys are following me there. And if you're not, and if I'm talking too fast, please let me know. So if 1 and AVL are seeing them as an ST, or are seeing the infarct as an ST elevation, what's happening on the other side of the heart? That's the question. So on the opposite side of the heart, they should be seeing the exact mirror. They should be seeing the exact opposite of what's happening. So in other words, they should be seeing an ST depression, okay? Because they're seeing the infarct from the other side. And this is called a reciprocal change. Now, let's go back to our let's have a look and see. So in this particular one, where 1 and AVL are seeing ST elevations, leads 3 and AVF should be seeing ST depressions and possibly even AVR, depending on where the infarct was. So let's have a look and see if that is really the case. And if we look at that, we see it is really the case. Leads 1 and AVL are looking at the high lateral side, and they are seeing an ST elevation. In other words, they are seeing an infarct. So the question you may ask is why does an ST elevation occur? This has to do with repolarization. And unfortunately, as the heart gets damaged, the ability of the chemical channels to be able to provide or create an action potential is decreased. And this is what actually leads to the heart having a higher resting action potential than what it normally would. So that's what an ST elevation is. So 1 and AVL have an ST elevation. The mirror image is seen on leads 3 and AVF, which are on the opposite side of the heart. We don't see it that much in lead 2 because it's not exactly across the spectrum, and we see it slightly in AVR because it may be just extending a bit downwards. I hope that makes a bit of sense. I hope you guys understand that and what I'm trying to put across. If we were to come to the chest leads, we see V1. It has what we call a right bundle branch block. It's incomplete, but we'll discuss that hopefully in time to come. In leads V2, we have also, I suppose you could argue there's maybe an ST elevation there. But what you've got to do is actually draw your line across, okay? And if you look at your line across, you can actually see that where the ST elevation starts, it's actually more or less in line with the rest of it. So it's not really an ST elevation. The same with V3. If you come there, it may look like an ST depression actually, but it isn't. If we come to V4, and this is a good trick for you to learn, especially if you're not 100% sure. Let's come to V5. So V3 and V4 are the anterior parts of the heart. The V5 and V6 are the other lateral leads. So in those, we see that there's not much of an ST change. So what we have here is that we have a high lateral infarct with reciprocal changes. So if you as a junior doctor, when I say junior, I don't mean an intern. I mean, you could be ComServe, you could be MO working in the emergency department. You now have a patient where you can definitively say, I have a patient with the high lateral MI with reciprocal changes, and the patient is symptomatic. They have chest pressure and they have diaphoresis as well. And this is the type of thing that you are now going to explain to the physician or cardiologist, depending on where you work, and you're going to try to explain to them that this is why you now need their assistance or their guidance, depending on the type of unit that you work in. So if you're working in a high-level emergency unit, you would immediately start the patient on thrombolysis, which has its own set of rules. Or alternatively, if you have a cath lab with PCI available, you may want to take the patient in for balloon catheterization and reperfusion and things like that. So I just want to stop for a second and just get an idea from you guys. Does sorry, does that make sense? Do you understand the point that I'm trying to get across about reciprocal changes? So, for example, if you had an infarct over here in AVR, you would expect to see reciprocal changes in one of these, possibly even these, but you'd expect to see it there. No? Okay, thanks. Okay, so one person has said yes, that's great. Okay, so that means I have a more or less 10% success rate, which is better than I've done throughout my whole life. So thanks, I appreciate that. uh, and let's say, for example, you had an infarct that's going through leads 3 and AVF, for example, or leads 2 and AVF. Let's think to ourselves more or less where we're going to have our reciprocals. So let's say we saw our ST elevations here in leads 3 and AVF, then we'd expect to see our reciprocals in AVL or 1. If we had our infarct here in 2 and AVF, again, we'd be looking at leads AVR, possibly AVL, maybe not in 1. So this is how reciprocal changes work. It's literally, I can see something from one side, so from the opposite side, it looks the other way around. That's it. That's all that a reciprocal change is. Now, a similar thing happens in the chest leads. So if you are looking at V1 and V2, it's a bit of a different situation in that when you get ST elevations here, we do consider it a septal, and you may see ST depressions, for example, in V5 and V6, and you may also even see it in lead 1. Because these are orientated horizontally, they can sometimes present with slightly different presentations, but you do see them, that's for sure. For example, in many anterior infarcts, you often see the inferior leads giving you reciprocal changes. Okay, so this is all that a reciprocal change is. There's nothing else. Now, this particular diagram is a very interesting diagram for you to just keep in your head. You don't have to remember the degrees. If you're becoming a cardiologist or a physician, you definitely need to know them. But, as anybody else, even if you're becoming an orthopedic surgeon, it's good to have these, because at least you have an idea of what could be going on. So, they do say the most dangerous thing in medicine is an orthopedic surgeon with an ECG. And it is true because they don't really know what to do. But don't quote me on that. But yeah. The other one is why do orthopedic surgeons wear stethoscopes? Because their friend gave it to them and they have to show it off. But anyway, enough about the orthopedic surgeons. They're generally quite strong and can beat you up, so I won't make any more jokes about them. Okay, so that's basically how reciprocal changes work and how we would, talk about our patient. So now that we've decided, okay, this is our patient, we have an acute infarct, whatever it may be, but we have an acute infarct. The question is now, what are you going to do next? Now, this is just the answer to the ECG that we had to look. So SP just stands for sinus bradycardia, which we had seen. And one piece of advice to you guys, especially if you're somebody who's not experienced, anytime you see a bradycardia, regardless of when it's a sinus bradycardia or any other type of bradycardia, always ask for help. Don't send the patient home. Do not let the patient out of your sight without somebody who has more experience having a look at the patient. There's a lot of things that cause bradycardia that are quite serious and can't always be picked up just on an ECG. There's electrolyte imbalances, there's direct trauma, there's ischemia, there's quite a few things. So if you see bradycardia, just ask for help if you're not 100% sure of the cause. Generally, the only time we don't worry about bradycardia is in elite athletes or athletes who are extremely well trained, that's the only time. Now, if you're not faced with somebody like that, I would suggest get help, get somebody to have a look at the patient before you send the patient away. All right. So the rate is just 45, which is quite low, and it's due to the lateral MI, unfortunately. Okay. So going through this whole thing, basically what it tells you is what I've been telling you so far, and that it talks about contiguous and non-contiguous leads, which I'm not too worried about now, because it's not something that's of great importance to you at your level. The only thing that would be of interest is this patient is a candidate for acute reperfusion therapy, which is immediate PCI. Now, for those of you working in, like I say, very advanced units, you will have access to this, which is percutaneous coronary insufflation or balloon inflation of the coronary arteries. But for most of us working in rural, semi-rural areas, we'll only have access to fibrinolytics, such as alteplase, heparin, these types of drugs. Yeah, I've already spoken for very long. So I'm going to try and cut down a little bit. It's time we've only got 10 minutes left. Yeah, so let me just get on to the last bits. Okay, so this is something that you can take as a screenshot later on. It just gives you a very basic breakdown of what you need to do. But to give you a very, very, very simple breakdown of what happens here, you give the patient oxygen, you calm the patient down, and you examine the patient, and you try and get them out of pain, and you try and dissolve as much of the clot as you can. The way that you dissolve the clot, aspirin immediately. You try and increase perfusion with things such as TNT, although it doesn't always apply. You anticoagulate the patient, not necessarily with heparin, but that's one of the options that you have. These days, we also have things like clopidogrel, which can prevent platelet aggregation. There's quite a few things, and it depends on the situation in which you work, what they have available, and then you get the patient ready to actually, be treated. Morphine is your best friend because morphine brings down your adrenaline surge that happens with the pain. And unfortunately, adrenaline causes the heart to beat faster. And when the heart beats faster, it uses more oxygen. So by bringing down that heart rate, you are also helping the patient. You can give beta blockers, but I wouldn't suggest it as an initial treatment. That is normally kept for once the patient has been reperfused. But in some units, they do advise you to do it immediately. Okay, and this is just a little flow chart of what you can do as well. But that's just a little thing. Generally, the treatment doesn't really fall to the emergency physicians unless there's nobody else available. There's nobody else there. Okay, I've still got 8 minutes remaining on this chat before they cut me off. Please, if there are any questions, now is the time. I'm going to go back to the ECG, and anybody has any questions whatsoever, now is the time to ask. If you need me to change the slide, just tell me. If you guys want to watch that video of that Australian breakdance, I think I've got it somewhere. But that's only like a minute and a half, so I'm not sure if that will occupy everybody's time. Or if everybody's happy and if they want to end, that's fine as well. You guys can let me know on the chat or you can talk. Let me bring up the screen here. Okay. Yes. Hopefully everybody understood what you went through. My aim with these new lectures is to just go back to the beginning, because what I've realized is that a lot of people kind of missed out on the basics, and I had moved on especially with some of the uh, the videos, moved on to very advanced, or let's say not advanced, but intermediate topics. So my hope is that to give you guys a chance to learn things that you'll see on a regular basis so that you can implement it and help patients. Like, for example, on Saturday, I'm hoping to teach you guys about the lateral view of the wrist. It's something that people often miss and misunderstand and don't know why we do it. So I'm hoping to do that. But on this particular one, if everybody's okay and everybody's happy, can just give me a nice thumbs up, and we can kind of call it a day. Uh, I leave it up to you guys, whatever you all prefer. Um, okay, let's have a look and see. Oh, thank you very much. I appreciate that. Yeah, morphine on a brady, that's 100% right, Indamo. It is counterintuitive. So I just say, like I say, morphine is your friend. In this particular case, you're 100% right. We wouldn't actually administer morphine to this particular patient. Very good question. Thank you very much. So that's why I say, we have to take things on a case-by-case basis. So in this particular patient, you would actually avoid morphine. You're 100% right, but you would aim for reperfusion. So what you would be aiming for is things like TNT. You'd possibly give the patient clopidogrel. And if the patient was in severe pain, you would give very low dose morphine, possibly a milligram, but not more than that. The thing is, you'd have to look at the bradycardia. Now, we have something called stable bradycardia and unstable bradycardia. And if this patient was in unstable bradycardia, then you would start treating the bradycardia at the same time, because the worse your bradycardia, the worse your ischemia is going to be as well. So that's 100% right. I can't fault you on that question. So you would, for example, look at things like atropine, adrenaline. You would look at inotropic support, but you may look at more controlled inotropic support, for example, with Dobitrex, dobutamine, things like that. But in this case, you're 100% right. What I had mentioned in let me just get to that. Um, Sorry, just here when we were talking about it, it's just a general rule, So let's say you had a patient who wasn't bradycardic, or let's say had a good heart rate to a high heart rate, morphine is your friend. But you're 100% right. In this case, you wouldn't rush to morphine, that's for sure. Even if you had very low BPs, you wouldn't rush to morphine. You'd have to take it on a step-by-step basis. For example, even a patient who's got an aspirin allergy, you're not going to run to give them aspirin. A patient who's got a right-sided MI, you're not going to rush to give them TNT. So there are certain things that you do have to look at. So that's an extremely good question. I really like that question. Thank you so much for that. And it helps me to think of things as well. Okay. Somebody else just made. Okay, no, thanks. I hope you understand. But the main point of today's lecture was just so that you guys can understand why an ST elevation takes place and what a reciprocal change is, and just to understand the orientation of the leads. So I hope everybody understood that, and I hope you've got the hang of that. I hope you will join me again. Next week, Monday and Wednesday, I'm going to try and do, other ECGs again, and on Saturdays, I'm going to try and do other things. For example, like I said, this weekend will be wrist X-rays, and maybe take it further from there. But if everybody's happy and there's no more questions, we can sort of can call it a day. And I really want to thank everybody. I really, really, really appreciate you guys joining me. I know it's not a nice time, 7:45. It just has to do with how we have our shifts at the Madideni Hospital. So I'm trying to accommodate the three shifts so that they all have a chance to also get involved on these as well. So I really, really, really appreciate you guys joining us. No problem. Nkosi, one last question. It's no problem. Got about 2 minutes left, so you can just quickly type it in. Thank you, dear. I appreciate that. Okay. So, yeah. Are we just waiting for Dr. Nkosi's question, and then hopefully I can answer it in the time remaining? I hope it's not a very long question because the time is running out. Fortunately, this is the free Zoom. So I was telling them on Monday, I can't afford why no treatment on the right side of the block? Okay, that is a long answer, but what I will tell you is that TNT causes vasodilation, which is what helps you to actually reperfuse the heart. The problem is that the right side of the heart is very dependent on the vena cava being able to support blood coming into the right ventricle. And as soon as you dilate that vena cava, it decreases the amount of blood that can reach the right ventricle. So it becomes a vicious cycle. Every time you're trying to get blood in, your vena cava is more dilated, so there's less blood going, and then there's less blood for the right ventricle to pump through, and that's why it goes. I've got a very good lecture on that if you want to go through. I'll try and put it up on the group as well, so that you can have a look at that. Okay, the time is about to run out. Thank you so much, everybody. I really appreciate it. I'm going to load this up on YouTube, and I will load that one on the right side of the heart and why we don't use TNT. Okay, thanks a lot, Dr. Nkosi, for the question. Thank you, Dr. Ndamu, as well. Please, everybody, have a great night, and hopefully we'll see you again soon. Okay, bye.